We're really delighted to have Professor Marion Saville here to share with us a perspective about the development of low-cost, high-quality point-of-care tests for HPV. I can't think of anyone who really is in a better position to share perspective about that than Dr. Saville. She's an anatomic pathologist. She is the executive director at the Australian Centre for the Prevention of Cervical Cancer, and she has been such a leader for the transition from cytology-based screening to more accurate testing with HPV. She has also been a champion of universal availability of self-collection of samples for cervical cancer screening. She currently chairs Australia's National Cervical Screening Program guidelines, and she is a leader in a program called the Elimination Partnership in the Indo-Pacific for Cervical Cancer, EPIC. And in recognition for the work that she has done to improve women's health through cervical cancer screening initiatives, she was appointed as a member of the Order of Australia in 2020. So please join me in welcoming Professor Marion Saville.
I do want to acknowledge that in the audience, as well as collaborators from MD Anderson, Karen Canfell is travelling with me up in the back row there, and of course I haven't done anything that has been achieved in Australia without Karen's involvement, and Karen actually leads the EPIC program from the University of Sydney that my organisation collaborates with. So cervical cancer elimination certainly is a team sport, and we need all hands on deck. So just what I'm aiming to give you today is really the framing for what tests we need and why we need them. And of course, you will all be aware that WHO called for elimination of cervical cancer as a public health problem back in 2018. And then in November 2020, announced this strategy to achieve elimination. So you'll all be aware of the 3-pillar strategy. We need 90% of girls vaccinated against HPV by the time they reach 15. We need at least 70% of women globally to have HPV tests, 2 HPV tests by the time they're 35 and 45, and we need 90% of those with disease detected, whether that's pre-cancer or cancer, to have access to that treatment. It's a big, ambitious goal, but of course it's the first and only cancer so far that the world really has the possibility of eliminating, and it is really a very highly impactful cancer globally. I won't go into that. This is modelling from Karen's team that projects that up the top there, the incidence graph you see, that Australia could get there as soon as 2028, but the time period is 2028 to 2035, and the language our Australian government uses is that we expect to achieve elimination by 2035. You will notice that little uptick in the incidence, but not in the mortality graph below. And of course, that's the modelling predicting that we will find a few more cancers through screening with HPV. So this is just after the introduction of HPV-based screening being a more sensitive test. And of course, that brings forwards diagnoses, downstages cancers, and we hope reduces mortality. Australia aims to reach this goal, and we developed a strategy for Australia, the National Cervical Cancer Elimination Strategy. And really the focus on that strategy was recognising we expect to get there quite soon, and possibly, probably the first in the world, although there is a bit of a pitch battle with Sweden underway as we speak. They definitely want to beat us. But a determination was made that we really need to get there equitably, and of course we do have equity challenges in Australia. Our Aboriginal and Torres Strait Islander population are more than twice as likely to be diagnosed with cervical cancer, and almost 4 times as likely to die of it. We did identify other priority groups where we have data gaps, so that's very difficult to monitor, but nonetheless we are doing some things. So how did we get there? We had technical working groups, and we had an overarching equity working group comprised of representatives of our priority populations who fed into our vaccination, screening and treatment working groups led by really technical experts. And we hope that by bringing together this methodology, we would end up with equitable elimination of cervical cancer. And this is just to show you the document on the left. It's readily available online and freely available. Our value statement there at the top following consultation. And you can see there the diverse range of priority populations that we are aiming to provide our culturally accessible and inclusive services to. Again, we do have some data problems with identifying people with disability, people who are gender or sexuality diverse, and culturally linguistically diverse people. We also have some difficulty in our cervical screening program, in particular, identifying Aboriginal and Torres Strait Islander people, but we have a good idea about who's living in rural and remote communities, of course. So the Elimination Partnership in Cervical Cancer, which has been renamed from including the Indo-Pacific, because we're hoping that this program is going to go more broadly than the Indo-Pacific, although it certainly has its roots in the Indo-Pacific. This was launched in 2023, and it was a 5-year funding tranche by the Ministry of Foreign Affairs and Trade, and it's supporting cervical cancer elimination in the region with improved sustainable health outcomes and equity, and really working with partner countries in the region. And as you can see, that slide, which is now quite old and needs updating, you can see again there are a lot of collaborators that are needed to get there. So what is EPIC? EPIC is an end-to-end attempt to address cervical cancer, starting with vaccination all the way through to cancer treatment, including palliative care, and to strengthen those services and work with partner countries to fill gaps in those services. And so we have these priority areas of work around strengthening vaccination program delivery. We are not funding vaccines, but we are strengthening program delivery in a number of countries. We have secondary prevention. I'll say a little bit more about screening. We work on lab strengthening, obviously in the HPV area, but also particularly in the histopathology area, so cancer diagnosis and so on. I was very interested to see some of the new technology that might be available, for example, looking at tissue taken out to treat cervical cancer and to look at the margins without the need for the kind of equipment we would have in our labs in Australia and you have in your labs when you want to look at histopathology. So that's very important. I come from a cytopathology background, and I think there's less and less of a need for cytopathology in cervical cancer elimination. We also have a digital platform called CanScreen, which I'll say a little bit more about, but it is essentially data capture to support screening, and based on the sorts of cancer screening registries that Australia, New Zealand, the UK and the Nordic countries all have, a complete picture of any tests relevant to cancer prevention, so that we can see a patient pathway and we can intervene when follow-up and other appointments aren't happening to remind those people. Of course, these registries were designed in Australia and similar countries, and a lot of it was based on letters through the post, you know, that old-fashioned thing. And what we did for CanScreen, and particularly in the concept of EPIC countries, is design something that works in a lower middle income setting that is platform agnostic, supported by a cloud-based solution. And really, we're communicating not with letters in countries that don't have postal delivery services, but these days the most common request we get from countries is to support WhatsApp communication to get in touch with patients who haven't had their follow-up following typically HPV detection. And of course, pillar 5 is really important. It's about everything around cancer diagnosis and treatment. So histopathology, diagnostic radiology, oncology, gynae-oncology, and of course radiotherapy is a really important piece of this, so it's very important. And last but by all means not least, and probably in a new iteration of this graph will be an underpinning across all pillars, is the importance of modelling and policy support across the elimination pathway. It's really important that countries are making rational decisions and they have the data they need to put business cases. And of course, Karen and her team are really the experts in this, having supported the modelling globally for the elimination strategy and updates to the guidelines. Apologies. So I want to concentrate a little bit on screening because of the audience, and this is a model of screening that was developed a little bit prior to EPIC, but we've carried it into EPIC. So first of all, self-collection really helps us with a lot of barriers in all settings, but particularly in resource-limited settings. So first of all, it's very much more acceptable than speculum exams for samples, and secondly, it allows this task shifting. So the health workers that are in very short supply are not needed to facilitate screening, but they are needed to see people in whom HPV is detected, so that's important. We found that using self-collection and then the Gene Expert instrument had very high performance, sensitivity and specificity, and very high acceptability. And that was in Papua New Guinea. And this is a very difficult environment in which to work, and the technology is very resilient. We were able to teach nurses in Papua New Guinea to run the tests and also to do the visual assessment and then the treatment with thermal ablation. So this is the model here in one. And what you see there, the registration, it actually happens on the same laptop that is supporting the Gene Expert instrument, and it's all tied together with barcodes on everything that moves, the swab, the cassette, etc. And so that brings all the information together onto the digital platform. And this is CanScreen, just to explain what it is. It's a platform as a service hosted in the Azure environment. We haven't gone over to other services, but we could if we were asked to. And it's designed and architected for the management of population health programs. It's particularly strongly configured for cervical screening, but can be used for almost any population health initiative. And so it supports two really important things. One, I've talked about that follow-up pathway, bringing people who are test positive to treatment and completing what they need to complete and recalling them 12 months later. You see there the interface on a mobile phone, so it's device agnostic. Any device can be used, and we don't need to buy special devices for the program. And then, of course, it also provides reporting at the program level, so the performance of the program, who's been screened, where they live, where they are in the pathway. We can identify geographic areas that are underserved. We can identify services that are having problems with follow-up, and that gives the basis to come in and to give some more support, and it's conceived in a continuous improvement model. It can also support research initiatives. I won't go into this, but just to say we are asked to integrate into electronic health records in a number of locations, and we do that because the criticism of CanScreen is it's a vertical system, and they want to have a whole horizontal system, but by the time that gets built, it'll be 5 years, and so we're putting this in countries saying, when you want to migrate to your system, we'll help you migrate. We'll come out. It's fine. It's your community's data, and you, as the ministry, are the data custodian. We will work with you, as a not-for-profit. And what's been achieved with this model is that in a typical day, 3 nurses are screening 32 people. And of those 32, approximately 4 in this setting will be HPV positive and will be seen in the afternoon. Most of them are eligible for treatment. And so of 100 screened women, about 1 in 100 will both be HPV positive and not suitable for thermal ablation. And that woman requires referral to a colposcopy service somewhere where her cervix can be examined and she can have an excision of the transformation zone as needed. And also, of course, we will find patients with cancer and they need to be linked to cancer treatment services. And so this was called the ECCWP program. It was the predecessor to EPIC, and probably because it was working really strengthened our application for further funding. And you can see in their community launches both in Papua New Guinea and Vanuatu. And Vanuatu has been using the elimination planning tool from Karen's group, and they are hoping to be the first lower middle income country to achieve elimination based on that modelling. So HPV screening tests, and that's really the reason why we're all here today. I'm sure anyone working in this space is aware of the target product profile document. It's a very lengthy document in some ways, and outlining the requirements for tests as WHO sees it that will meet the needs of communities and the elimination agenda. And so it outlines these requirements, and it specifies what it calls minimum and preferred characteristics of testing. Two separate sections, one for laboratory-based tests, another for point-of-care tests. And it is focused on resource-limited settings and to support elimination targets. Many of you will know that IARC have recently reclassified HPV types in relation to their carcinogenicity and put them into these 4 groups now recognised. For people who might expect to see types 66 and 88, they are no longer there. So what we're looking at here is prevalence in cancer, so in a way attributable fraction, and you can see that that group is organised by that attributable fraction, and you see HPV 16 right up the top there, more than half, 18 and 45, and grouped into types 1A, 1B, 1C and 1D, and as you go down, these types are less and less likely to cause cervical cancer. And actually there are more types beneath this, 66, 68, 73 others that are no longer considered by IARC to have a sufficient attributable fraction to be considered carcinogenic. And then the other consideration is the prevalence in people with a normal cervix in the second column on the right. And that's really important because we don't want tests that have low levels of carcinogenicity but high levels of community prevalence, because that's going to cause specificity to go down for not very much gain. So that's really important. And so this is the way we would like to see any grouping in HPV tests taken, and I think this will inform the language. People will start using this group 1A, 1B, 1C, so I think it's really important to line things up with that, which has been used in the TPP. And there are these 2 sections of the document. We're really interested in point of care for a whole range of reasons, not the least of which there's only really one assay that's working really well in resource poor settings, and it's too expensive. So there's a real need for more entrance into this market. The lab-based market, relatively speaking, is already much better served and much more competitive and better priced. These profiles are in detail. I'm just flicking through this so you can see the range of considerations that are in there. I would refer you to the document for particular things. I'm not going through them one by one. You'll be relieved to hear. But looking at the target price per test, you see there, we're really aiming to get this test down from about $16 US or $15 US down under that $8 US, and that's all in as cost per reportable test, as the TPP articulates them. So that's the goal. I do just want to talk about how we might use genotyping, and again, I'm talking to an audience with Karen here, and her modelling team informed these WHO guidelines. And of course, we can talk about triage, but in a way with the right test, we get the primary screen and the triage in one product, and that in itself is A, cost saving, and B, doesn't take further time. I mean, cytology as triage means it's got to go to a lab. We don't have the community to do that, and as a cytopathologist, I can tell you it's just not realistic. Some people have suggested with those lower level oncogenicity tests, we could triage that group and triage them with VIA. So visual inspection with acetic acid has not got a lot of support for its effectiveness, but it is important to have a look at that cervix, and most particularly, we're now talking about HPV types that are not so oncogenic, and depending on your ability to get these patients back, having been screen positive and triage negative, it might be a viable strategy. But for me, one of the most important things about that VIA triage in a patient who's carrying HPV who you're not going to treat is someone has looked at the speculum of the cervix, and if there's a cancer there, it's probably going to be found and managed. That's really, really important, because we are talking about screening hundreds of millions of women worldwide who've never had a test. And so some of them will have had an HPV type for a very long time, and we really need to make sure that they too get the care that they need. So that is a possibility of using a 12-type test where you take out and separately identify group 1D, if you've got the capacity to do that. And again, as you'll see, that comes down to a lot of things, but most critically, your ability to get women back at that bottom part if the VIA looks negative. So we use this language about genotyping, and some parts of the world, believe it or not, some quite high-income parts of the world are using tests that give you 12 to 14 types, and they don't, including 66 and 68, and they don't give you any breakdown. So it could be anything from 16 to 39 that have very, very different likelihoods of being associated with precancer or cancer. Then what we're now calling limited genotyping, the separation of 16, 18, plus or minus 45, where those types are going in high-income countries, and particularly in Australia, direct to colposcopy, and other types are being triaged. Extended genotyping, so we're looking here probably most usefully at those IAC subtypes. And then there is full genotyping, and I'm not sure that full genotyping adds much, although there are some low-cost tests and one manufacturer that we use sometimes in our lab, and that's interesting epidemiologically, right? But it is not really adding to the clinical management beyond the extended genotyping. There aren't any tests that absolutely exactly line up with this, even in the lab space at the moment, so manufacturers are scrambling. I think Roche have announced that publicly that they are going to a test that will be fully genotyping, but not necessarily to report it out that way, but using a software overlay to report out the groupings. And that was a plan they came up with some time before the TPPs were launched. And I think manufacturers, and you can see it here, have got a bit of a problem, have had a problem about how to extend the genotyping and which type should be where. I think that question has been answered now. But on the left-hand side, you see, for example, HPV 35, which is important and included in type 1C, particularly in Africa. It's an important type. It's there with HPV 39, and which would be in 1D, and 68, which we wouldn't even include. So in order to find that type, you've got to actually see patients that have any of the three types. You don't know which one it is because it's all reported out in the same channel. So you can get the picture that we're in a process of manufacturers doing the lining up. But certainly for de novo assays, we want to line up according to that IARC classification now. And then treatment here is ablative treatment if possible. So this is how WHO sees the management of people who have ablative treatment. Those not eligible for ablation do need a large loop excision, and where you've got histology, they're encouraging countries to do that, acknowledging it's not always possible. And certainly those with cancer need to feed in through the cancer clinical pathway. This is some modelling that was published with the update to the guidelines. Again, just acknowledging Karen's team input here. And here you see amongst people having 10-yearly tests, 30 to 50 years of age, no screening up the top, and then the relative reduction in incidence in the first column here. Let's see, don't think I can point it out. The first coloured column there, and you see that you're getting about a 50% reduction in incidence and a slightly higher reduction in mortality on the right, so that's great. And then you see the impacts for the various types in terms of pre-cancer treatments, numbers needed to treat to avert a cancer death, and lifetime costs averted. And then this right-hand column, which is called resilience, which is the absolute difference in percentage points terms for the mortality benefit when follow-up is 30% or less. And there you see that the strategies, say 12-type triage with cytology, triage with colposcopy, because of the failure to get follow-up, particularly for triage negatives, is not nearly as good, and you lose a lot of the mortality benefit. But the strategies where you see and treat, the 12-type, or even my current favourite, and firming up as a favourite for many, is the 8-type. So we're testing only for types 1A, 1B and 1C, 8 types, and we're using visual inspection with acetic acid to treat everyone who's eligible, and anyone not eligible then needs to go to a district hospital typically for colposcopy. And that has very favourable characteristics. And what this part of the guidelines is trying to do is to have countries think about their capacity to do recall and to get patients back for treatment, because if you do a lot of screening and you even do triage but you can't get those patients back, it's a lot of activity, as you'll see, without that much impact if follow-up is low. And so again, in this annex to the guidelines, you can see how we're thinking about it. So as you go across here, we get lower and lower effectiveness in terms of preventing deaths. And as we come down on the left-hand side, less and less cost effectiveness. And the ones that are up the top left are therefore more favourable and are therefore treating all positives, are there with treating all 12 types, or here in green on the right, either treating types 1A, B and C and using triage for types 1D, or just treating using colposcopic and other methods. So the idea is, as I said, that resilience is so important if you want to have complicated strategies that we use in Australia and the US and other high-income settings. They're not going to give us what we want in fragile health systems, and so the see and treat model becomes incredibly important. And of course that leaves us stuck in a test desert with only one very expensive test that's suitable, and therein lies the most important problem and the reason for our visit here to Rice and to MD Anderson. So this is with high follow-up here, and then with low follow-up, the differences are much, much more stark. And so even just treating types 1A, B and C has huge impact, and particularly because you're not losing people. And so the recommendations, if you go to the WHO recommendations, which were launched in May, again, encourage countries to look at their follow-up capacity and are favouring extended genotyping or limited genotyping versus treating all in a high follow-up capacity, but in low follow-up capacity, treating all HPV positives over limited genotyping, over triaging all positives. So really encouraging countries to think very carefully about what it means for them in their settings. And so this is the gap in the point of care marker. What I wish for is an HPV assay that includes at least the 8 types specified by the TPP or the 12 types. But actually, there's an argument for the 8 types first. getting there, as we've discussed. In the latter case, if we've got 12 types, we at least need 1D separated out, the ones that don't need necessarily treatment today. We really need to support self-collection, and based on the evidence at the moment, that means we need a cellularity control in an assay that we're going to use in the self-collection setting, and it needs to be based on nucleic acid amplification. We must have tests that are clinically validated against CIN2+ outcomes in accordance with international consensus. The paper that I've cited there is about to be updated. There's a forthcoming publication on updated consensus guidelines about how that's done and what the comparator assay criteria for new comparator assays as well. And of course, we need resilient technology for fragile health systems, that should be, and I don't need to tell anyone here that. And of course, we want to meet the TPP target price. So our lab in Australia sees anywhere from about 200 to 500,000 tests a year, and about that, depending on where we are in the cycle. And that means we have a lot of screening assays coming through, and through our national cervical screening register, we understand the outcomes of patients, so we can put together tests pretty readily. We went through the pain of becoming listed by WHO as an HPV performance evaluation laboratory. We were the fourth and we are the last in the world because WHO has decided they don't need performance evaluation laboratories, but they will accept evidence from published validation studies in accordance with international consensus guidelines. It was a good exercise for us, and we were very pleased to be able to say that we were listed, but about 3 months after we achieved that, they wrote and said, please take this off your website. In any case, I think it's been a useful process, and we are very keen. We did this because what we want to do is accelerate the time to market for candidate assays. We're not test developers, but we understand how tests should be performed, and we can do a validation study in about 6 to 8 weeks from the beginning of the process to writing a report. We've done a number of validations, and down the bottom you'll see the assay evaluations that we've undertaken that have either been published or in the process of being published. But a huge part of our work has been validating self-collection devices and protocols, because even for the lab-based assays, we introduced self-collection in Australia as a choice for all screening candidates in 2022, and now we've just clocked over half of our tests are all self-collected. But at that time, the manufacturers of the main assays that labs wouldn't know didn't have any claim about self-collection on their information, and so we were required to do in-house validations and to support laboratories around Australia to do their in-house validations until these came on label. We still have a problem with the Roche method, which says it's not suitable for use in pregnancy, and yet most people get a swab late in pregnancy to rule out group B strep. So I think some nervous lawyer said you better rule out pregnancy. Now that is a huge problem for us, because a lot of people that will not otherwise intersect with the health system in a country even like Australia, we can screen them through their antenatal care. We should not miss that opportunity. So we have done that validation. And I was persuaded that we should validate the COLI-P, much to my great chagrin, because I'm not a fan of urine self-collection. I think it's technically challenging. And I think its requirements won't be that great for resource-limited settings. I think a lot of people will write PhDs about it, though. But I was persuaded that we should be part of it. I'm not also sure what problem it's trying to solve, because we have very high acceptability of vaginal self-collection, mid-90%. Some people are claiming that lots of cultures don't like it, won't do it. When the communities we've been involved with have not had that problem. So, it would be a smaller group of people wanting to access urine, and you have to have first pass urine for the concentration, because there's quite a loss of sensitivity in urine. So that's why this COLI-P device came about, and actually it's more than the $8 that we're looking for the whole test all in, so it's not cost effective, and I don't think it's our most important piece of work, but I was persuaded to do it. We also support laboratories around the region with proficiency testing and education and quality frameworks, but probably one of the most important things we've done is this QC material that we developed with Microbix. It's now, I believe it's lyophilized, and we get a very good price. So we have a network of programs that are using, in particular, Gene Expert, and we worked with Microbix to develop this particular QC, and I think Dave's working with them to get another swab that has types other than 16, 18, 45 to look at each of the channels in the instrument. But we might look at a 1B, 1A, 1B, 1C, and 1D type, for example, because we want to know these channels are working. And they can be used for routine QC, but we also use them when we're training nurses to run the Gene Expert instrument and run the assays, and we know what result to expect. So I am going to leave it there so we've got plenty of time for discussion, because I feel like I'm bringing, there's a saying, it's a British saying, you may know it, bringing coals to Newcastle here. Most people in this room probably know most of that, but it's just such a privilege to be visiting you and working with the Rice team and the MD Anderson team, and we're very excited. So thank you.
I have a question about sort of the fragility of the health system, which I think is fantastic. And I guess my question is, what has been your experience talking to ministries or regional governments, decision makers, when you have to sort of have this like realization that they in fact have a fragile health system but are not able or wanting to admit that? And I'm just curious, if in your experience, has that been a big challenge?
We haven't had the conversation exactly like that, I guess. And so for Papua New Guinea and Vanuatu, we started with a research study that looked at the model, and that was up in the Western Highlands province of Papua New Guinea. And when the research stopped, the team didn't want to stop. And so there was this advocacy and working with the provincial health authority, and the provincial health authorities, I'm sure it's the same in many countries, some of the subnational health authorities are really more on the ground in charge of what goes on. So we've had great support from them. We've had great support in Vanuatu as well. I was involved very early with the Rose Foundation, so that's removing obstacles to cervical screening, and that's led by Professor Yinling Wu, who is a gynae oncologist in Kuala Lumpur, and we met actually at a cancer meeting in Singapore and started a discussion first about self-collection, and then we did a research study again, and it went well, and then it grew from there. And I often say it's not about telling countries what they should do, but showing them what's possible. And I know that we don't want to do endless pilots that then stop, but we want to use them as stepping stones to expansion and national policy. And ultimately, and this is a really important thing that we've been working on in EPIC, is working on sustainable funding and handing this over to the ministries. I mean, we should aim not to be needed anymore. And one thing I've observed, having worked in Malaysia, where I was very involved on the technical side of it, I mean, they already knew their communities. Yinling's very proficient in as a gynae oncologist in colposcopy, but they rarely contact me now. They're sort of off and running, and I'm on their board still, so I'm there 4 times a year. But I understand what they're doing through their social media. They're not asking me first, they're off and running with it. And I think that's what we want to do. We want to empower countries, but I think it's a conversation about what's possible. And let's do a pilot so you can see how this works. We did have quite a conversation. The biggest barrier in Vanuatu was CanScreen. CanScreen is in Azure. There is not and will not probably be a major data centre such as Azure or AWS in those very small countries. We've recently moved the CanScreen instance for Malaysia to Malaysia, And that's timed partly because it's no longer just the NGO. The ministry is very seriously considering using it until they can build their own, which they say will take 5 to 10 years. I don't know. Anyway, they wanted it there, and we could move it there, but it's only a year after the first servers have gone into Malaysia. And what is interesting is when we first started, we said, you know, there's data centres in Singapore or Australia. You might get less latency if we put it in Singapore, and they said absolutely not. And this is this inter-country rivalry between like-minded countries. We have it between Australia and New Zealand. Australians would never have their data in New Zealand. They probably have it in China, fine, but not in New Zealand. And so you do have to deal with that. And it's really interesting because, in a way, in the absence of sort of legislation that says the country where it resides can go in and get anything, what matters is not where the data are held, but who can access them, that you've got proper security controls in place, doing penetration testing, you're updating all the security patches and all of those things. That's much more of a risk than anything else, than having the data in country. And Vanuatu is the country in the world with the highest number of natural disasters, and their data servers are in the basement of the hospital in a country that will get flooding due to cyclones and so on. So, you know, and again, CamScreen is mirrored, so it's always in 2 geographically separated servers for risk management. If we have a natural disaster in Melbourne, then the Sydney instance will pick it up. So, and we can go, you know, globally to any place that Microsoft or Amazon have these servers.
Right, we have a question from outside the room. What are the top 3 features you would like to see in future screening products, HPV and visual?
So one of the things that I've seen today excites me. It's the visualization to support colposcopy. I think that is really important. So definitely, I've told you what I need in an HPV test. And one thing that really interested me a lot, and I am really kind of humbled by the degree of difficulty of getting pathology into these countries. You know, just the basic H&E pathology is very challenging, and you only need one piece of equipment not working or one critical supply not ordered, and you have no pathology for months at a time in some of these countries. So this idea of being able to visualize through the microarray so with a LETS you have a cone of tissue, and what you're really interested in is the margin of that cone. Have you got all the disease out, or is there still disease at the margin, in which case the colposcopist can take more tissue, and probably should take more tissue in those systems where follow-up is poor. So being able to do that at point of care is very, very attractive as well.
So I was super interested in your QC samples. As a test developer, I think it would be very handy to have access to something like that early on in the test development process. Do you make those available to the community?
We can definitely get those and get them at very low cost price because of our involvement with the development. But Microbix are a Canadian company that we've been working with. And as I said, we are looking at a new product that will test across the different channels of the assays. But we'll talk to Dave and make sure they're 1A, 1B, 1C, 1D. He was there at the TPPs though too, so I'm sure he's got that in mind.
That's really great.
Yeah.